sure this is on. All right. Good afternoon. So for those of you who are in the way back, there are some seats here in the front because I think you will have a really hard time seeing other than on the TVs. So you are welcome to move. I know everyone likes to sit in the back, especially on Friday afternoons. But if you would like to have a better view, there are seats closer in. So please feel free to come closer. And it is terrific to see you all this afternoon. I do want to get us started on time because we have a very rich program. And I can tell you from spending some time with our speakers and our panel before this that it's going to be a lively discussion. So I want to make sure we have enough time for everyone to give their talks and for you to interact as an audience. And given it's Friday afternoon, I definitely want to make sure we get going on that. So welcome. I am Marianne Udow-Phillips. I'm the director of the Center for Healthcare Research and Transformation, and it is my great pleasure to welcome all of you this afternoon. This is such an important topic. And you know the topic is what really will happen with the safety net post-healthcare reform. Of course, we're assuming healthcare reform stays intact, that the court challenges are not successful, that the midterms don't produce a whole new repeal and replace approach or a starve the beast approach, much of which has been talked about. So we, for purposes of this discussion, are going to assume that healthcare reform stays in place, and certainly that the portion of healthcare reform that deals with the safety net, which is very much a bipartisan support in Congress for the safety net and has really widespread implications, that portion at least will stay in effect going forward. And so we very much want to examine this question because, as you'll hear, there is much that we need to think about in terms of the safety net going forward. And it is not too soon to be planning the kinds of changes that the safety net will face. There are some who believed that the safety net would no longer be needed come post-healthcare reform. But I think what you're going to hear from our panelists today is that not only will it be needed, but in fact, in some ways, its importance will grow in a post-reform environment. And so we need to think about and plan for what those changes could look like and how we want to be prepared to handle what the implications are from federal healthcare reform. To have that dialogue today, we have a very exciting panel, and I just wanted to tell you a little bit about the logistics of the day, and then I'm going to introduce our first speaker. We are going to hear from the panel first. Each of the speakers on the panel will have half an hour to do their presentation, and then at the end of the three talks, we will take some questions from the audience. We'll have handheld mics. Just raise your hand, and somebody with a mic will come by and give it to you to ask your question. We are webcasting this forum this afternoon, and we're also going to be having it on our website subsequent to the forum. So I would ask you to speak into the mic so that we can clearly hear the question, as can the audience who's not here in the room with us. After the questions and answers for the panel, then we're going to bring the reactor panel up, who are folks who have really been in the trenches, who deliver this care on a daily basis, who represent the organizations who deliver the care, who are out there in the field in the communities. And they're going to talk from their perspectives about what they heard from the reactor panel and the implications for our state going forward. We will then, at the end of their presentations, have an opportunity for questions and answer for the entire panel, reactor panel and the speaker panel at the end. And after our session at 4:30, we invite you to a reception at the back for those of the speakers who can stay, and I think everyone but Sara can. We'll have an opportunity for more informal dialogue to continue the discussion. As I said, I know there's going to be lively debate among the panelists. They certainly do not all agree, and they all bring their unique perspectives to bear, and so we should have a lot of fun this afternoon. So let me introduce our very first speaker, and there are bios in your materials that give more detail. I don't want to spend a lot of time on the introductions, but I do want to give you just a flavor of the background. We're most honored to have Sara Rosenbaum here from George Washington University. Sara is perhaps one of the most experts in the country on the safety net. She writes about it, she studies it, she's practiced it. She comes both from the field and from the research world, and as well as having been intimately involved with the creation of policy around the safety net. She spent some time in the Clinton administration. She advises the Obama administration. She writes prolifically on many topics on healthcare reform, and I, for one, always read her articles with great attention because she is just one of the most knowledgeable and insightful people about a range of issues on healthcare and healthcare reform. She is an attorney, but who brings a policy perspective to bear, and we are delighted to welcome her to Ann Arbor and the University of Michigan. Sara.
Thank you very much for that kind introduction. It's lovely to be here today. I've been to Ann Arbor a few times, and I'm always struck at what a nice community it is. Peter and I go back, I won't even say how many years we go back, almost as long as I go back with Kim Sobilski, so it's great to be able to see friends here as well. A disclaimer at the beginning of my presentation. So I am here talking about, and I looked, actually, I don't use the term community health centers. I only use the term health centers. But what you are about to see in my slides and the remarks I'm going to deliver focuses on what we call under federal law, actually community health centers, which are designated as such under the Public Health Service Act. And more commonly, you may know them as federally qualified health centers. Federally qualified health centers include federally funded community health centers, as well as entities that meet all of the requirements of the federally funded community health centers program, but do not receive a federal grant from the Public Health Service. So there are many people in this room who are involved in community-based health center activities of all kinds, but my remarks are focused on those entities that are that we would think of as federally funded or federally qualified health centers. So, what did I do? Let's see. Okay, so a little bit of background, I think, before I get into the meat of my remarks about the newly insured and health centers. Many of these figures are probably familiar to most of you in the room, but it's worth sort of recapturing the statistics about health centers. A health center, of course, under federal law is a very special creature. It's a creature that has to meet a whole raft of federal requirements in order to get funding. It has to be structured and governed in a certain way. It has to offer a certain range of services. It has to discount those services for people who are unwilling to pay. And it has to be located in an area designated as medically underserved. And for those reasons, of course, and because the health centers program is governed by very comprehensive and stringent data requirements, health centers share a lot in common, although they vary tremendously. When you go to a health center, it, of course, has all of the characteristics of its community and its population, but nonetheless, they share a tremendous amount in common since they're a federally administered program. And their patient characteristics are remarkably similar in certain ways. So, for example, health centers all serve virtually only low-income people. Now, that actually, we're talking about this before the session began, that can vary in certain communities. There are certain communities in which a health center may be in a community because there's a significant population that's medically underserved, as measured by high health risks and a shortage of primary care or both. But nonetheless, the community is quite eclectic, and so you can find middle-income patients at community health centers. Nonetheless, the overwhelming majority of health center patients are low-income. That is, they have family income below twice the federal poverty level, much higher than the U.S. population. Health centers also, not surprisingly, serve a population that's far more racially and ethnically diverse than the U.S. population as a whole. About 60% of the population, patient population, is white, 27, almost 28% African American. Other races make up the group, and of course, it's a heavily Hispanic program. So a third of the patients are Hispanic Latino. Health center patients, again, thinking about this core requirement of health centers that they be located in areas that are medically underserved, as evidenced by population health factors, a shortage of primary care, or both. Health center patients are very different from patients served in a physician's office. So, for example, if you look at the percentage of patients served at a health center with serious and chronic health conditions versus the percentage of patients served in a primary care physician's office with serious and chronic conditions, it's almost a 3-to-1 ratio. And it breaks down, of course, by in a variety of conditions. So you have almost twice the rate of mental disorders, better than twice the rate of diabetes, 3 times the rate of asthma. Just as a sidebar, 1 in 5 children seen at a health center has asthma, so it's a very pronounced problem among pediatric patients, and almost 3 times the proportion of patients served with hypertension. Health centers have been able to, because of the comprehensiveness of their service requirements, because of their staffing requirements, because they were designed to be able to provide an awful lot of care under one roof, health centers, by and large, take on the characteristics of what we refer to today as a medical home. So they report on the quality of care. They all do. They must, actually, under federal law. That patients are involved in not just as community advisors, but actually in the governance of the health center. They all do, virtually all do some form of care management. They virtually all do some form of enabling services, meaning patient support services. The great majority offer some level of 24-hour coverage. The great majority offer on-site at least some level of behavioral health, dental care, pharmaceutical services, and the great majority have disease registries as part of their activities for 1 or more conditions. The proportion using electronic medical records is far lower, but of course it's actually far higher than physicians in private practice. It doesn't say too much about the rate of EHR adoption penetration yet in the United States, but it's a figure that is expected to grow actually pretty rapidly now among health centers. Health centers do well on quality of care measures. The federal government now collects from health centers and reports on quality of care measures. Here are some of the standard measures. More and more, the Health Resources and Services Administration, which administers the program, is becoming quite aggressive, as I'm sure Kim may mention, in moving health centers into standardized reporting along a whole series of measures that are the measures that we expect increasingly as a society to see physicians and hospital-based practices potentially get measured against. So here we see childhood immunization rates, we see pregnancy care in the first trimester, pap smear in the past 2 years, hypertension patients with controlled blood pressure, diabetes patients whose HbA1c readings are controlled. So these are all an indication both of the distance health centers like everybody else has to go, but also the fact that they all uniformly report now. So this is a sort of an aspect of the program that I think is important. Health centers are extremely cost efficient. Now, they're, quite frankly, I think they're extremely cost efficient precisely because of their structure. These are staff model clinics. They are mini versions of an HMO. In fact, a colleague who directed a health center for decades wrote his doctoral thesis here at Michigan on the similarities between the HMO Act of 1973 and the health centers program. They bundle a group of services together. Their staff are on salary. They have to provide comprehensive services. It has to be provided under one roof. There are referral rights at health centers, but predominantly health centers provide the bulk of their core services on site. And so they operate efficiently. They also sort of operate on a budget because while health centers get a lot of third-party financing, they're driven by, the most important funding they get is their federal grant. The federal grant sort of defines the program, and the federal grant requires that you think in terms of a budget. It's a project budget. What's your budget going to be? How many people are you going to serve? So there is sort of a prospective check on the structure of a health center, and therefore there is a great amount of attention paid on the business side of health centers to how they have to run, and so they run in an efficient fashion. They also have, because they're federally qualified health centers, they have certain benefits that not all community programs get. For example, for a federally funded health center, their medical liability coverage is through the Federal Tort Claims Act. They take advantage of drug pricing programs. They have other dimensions to their operations that help keep costs down. But mostly is this pressure, because of the federal grant, to operate on a project budget. And that project budget, that global budgeting requirement, has implications as to their overall costs. So over the last year, as health reform was being debated, and as the issue of a major capital investment in federally funded health centers was being debated, we undertook a series of studies that became known as Bending the Curve, and there were actually 3 versions of the study. We did one from the House bill, we did one for the Senate bill, and then we did one for the final legislation to try and gauge the cost effectiveness of health centers on a national scale. What we found was that because they are efficient operators, health centers today, if you look at the number of patients served, save about $24 billion annually, as against those patients receiving the same bundle of services in other practice settings. And the 10-year estimated savings that we derived were a savings of $362 billion compared again to the same bundle of services furnished in other practice settings. If you grew health centers to reach an additional 30 million patients. So in other words, if you presumed, as Congress ended up doing, that it was going to literally more than double the number and the patient capacity of health centers, the offsetting value of what became an $11 billion investment was about $362 billion in our estimate over 10 years, with $148 billion in federal state Medicaid savings, precisely because they're extremely efficient service delivery models for primary care. Now, there is an issue with health centers, though, and this is something that is extremely important to bear in mind. It obviously has implications for their responsiveness to a newly insured population. And the issue, which is an issue for health centers, it's an issue for any safety net provider, quite frankly, and it turns out to be an issue for other practices as well, but not quite as bad, is the problems that health centers run into with referrals. So you can see that compared to physician's office, 72% of patients at community health centers experience problems with referrals if they're uninsured. 54% experience problems with referrals if they're Medicaid covered, which is, of course, always a little scary because so many Medicaid patients served at health centers are in managed care networks. So the question is, why do we see these big numbers if they're in networks that are supposed to have, in plans that have specialty networks? Same is true for Medicare. Interestingly, the one place where health centers do better than private physicians is privately insured patients. Health centers have an easier time getting other providers to take their referrals. Now, my theory about this, nobody really knows why. These figures are reported from the National Ambulatory Medical Care Survey, but nobody really understands the dynamic here. My theory is that it actually is bound up in the sheer volume of patients that health centers treat who are uninsured or Medicaid insured. That is, their volume is so great, the number of times they have to make referrals of uninsured or Medicaid insured patients is so great that it's likely that they and their patients are more frequently likely to run into problems. But again, nobody really knows. Where are we headed in terms of coverage? If you look at the left-hand column, you see where we are today. We have about 20% of everybody uninsured. We have about 12% of the population getting Medicaid or CHIP. We have about 11% of the population in the private non-group market. And we have nearly 3 in 5 people in employer-sponsored coverage. It always amazes me when you think about the rhetoric around employer-sponsored coverage, that is the mainstream form of coverage, and we don't even have 3 out of 5 Americans in it under 65, but there you go. With health reform, we see this mass redistribution that happens. And you can see that the uninsured is reduced by better than half. It certainly by no means disappears, very important, but it does drop. Medicaid grows by 50%. So we go from 12 to 18% of the population enrolled in Medicaid, the non-elderly population. Exchanges, of course, the new model for the individual market and presumably the small group market, but really for this slide purpose, it's the individual market, grows by, again, about 50%. The individual market is expected to sort of go away outside of the exchanges. We'll see if that happens, but by and large, it will shrink way back. And according to the Congressional Budget Office, in the employer-sponsored market remains about the same. This is, I think, a little bit misleading only because there is an ambiguity about what happens to small employers who buy through exchanges. Do we consider those people to be people in employer-sponsored plans after 2014, or do we think about them as individuals who happen to work and get a subsidy from their employers to buy coverage? I don't think we really know the answer to that yet. But for this simplistic purpose, as you can see, CBO assumes that the number of people with employer-sponsored coverage, whatever that means, meaning that there's an employer who contributes to their coverage, remains about the same. The reform law, the Affordable Care Act, also, of course, grows the health centers program, and it grows it quite deliberately to start dealing with what is perceived as this enormous primary care shortage in the United States, and particularly in medically underserved communities. And so over a 5-year period, there is about an $11 billion investment in operations, in capital expansion, and an accompanying investment in the National Health Service Corps, which often staffs health centers. And the number of patients served as a result of this investment engine, coupled with the new Medicaid revenues, will climb as well. Here are the patients by insurance type. You can see what they are today. Today, the uninsured are 38% of health centers. It is expected to drop, but notice not by anything like what it will drop by in, say, private physicians' offices. In a study we did in Massachusetts, we found that after reform, the number of uninsured patients dropped at health centers, but nothing like what you would see in a private physician's office, nor should it have, because health centers receive their federal funds precisely to see uninsured patients. And so the numbers remain quite elevated. Medicaid, of course, grows from 36 to 44%. Private insurance, notice, is expected to actually drop a little bit. And again, I would say that some of that is the ambiguity of what we mean by people with private insurance, our exchange-sponsored people, people with private insurance, and how big a role do health centers play in exchanges. But the Medicaid is where the great growth is seen. Private insurance, of course, again, it's a much larger number of patients. By 2019 will be a significant part of health center business operations. What do we expect to see? A big patient surge, a lot of surging in new care seeking in communities with high concentrations of uninsured. These are the communities. We did a study last summer that essentially overlay the uninsured population of the United States with medically underserved area designations, and no surprise, the greatest gains in insurance coverage from health reform will, of course, be the places where that are mostly medically underserved today, where you have large numbers or large areas of population in fair to poor health coupled with a shortage of primary care. That's where a lot of the newly insured will be. They will surge in those communities, and health centers are being grown in anticipation of this. In a forthcoming study that we are engaged in now, looking at what we think of as the access challenge that states will face, the access challenge is a rather simple measure as far as we're concerned. It's the Medicaid numerical expansions as they're estimated compared to just simply primary care capacity. So not the more elegant medical underservice measure, but the primary care capacity measure. They're developed as a tool for projecting primary care growth. We see that Michigan will rank 19th out of 51 jurisdictions. So you are expected to have a major access challenge here. A lot of need for primary care growth, a lot of growth in the number of Medicaid patients because of your poverty, and a need for expansion. Health centers obviously will be the biggest single source of primary health care in a 50 million person expanded world, and then probably the most single important source of care for the uninsured, just again because they'll be growing so in size to a group of 50 million. The patient characteristics of the newly insured, they're sort of hyperbolic. A lot of young adults, singles with parents, simply people who are just lower income workers and their families excluded from Medicaid because of categorical exclusions or financial eligibility considerations, but also a lot of older adults with a heavier burden of chronic illness and disease who are too young for Medicare, are low income, and have been uninsured. A lot of mental illness, a lot of physical illness. We also, I think it's worth noting as an aside, expect a big surge in Medicare, Medicaid duals as the number of providers and communities who are willing to see dually enrolled populations also begins to shrink. This has been a growing population for years at health centers. And of course, nobody is going to have the pediatric adolescent medicine and OBGYN patient population go away. So whereas health centers have had a long history around families with young children, what we think is going to happen is they're really going to have to grow capacity in older, seriously burdened adults with multiple chronic conditions who now are being managed as uninsured patients often, but who are going to be insured. And health centers are going to have to respond to that. And it's a very different business model from the model of caring for people who are uninsured. Health centers in the new world, we think that a lot of their time will be spent on navigation links to eligibility and enrollment. They will be major participants in qualified health plans, and certainly just as they are in Medicaid managed care plans serving underserved communities. And one of the things that's going to be exceedingly important for the plans that health centers dominate or are predominant players in is a risk adjuster. Because of the burden of illness dynamic that one sees at health centers, because of where they're located and because of who they serve, their patient populations can probably be expected in a largely networked plan to continue to have the characteristics of greater illness. So even as they grow younger families with children, we may see a lot of the growth that happens in older chronically ill adults, particularly adults with serious mental illness, happening at health centers. Health centers will be major players in clinical integration. They're going to have to do this. They're going to have to do this because every provider is going to have to do this, and they're going to have to do this because of the referral problem you saw. In a world in which far greater numbers of your patients are insured, you're going to have to be able to practice like an insured practice. And that means growing the kinds of clinical integration that allows more easy referrals. You can see from the referral slide that even with a more integrated practice, referrals will probably continue to be a problem because there is a shortage. But nonetheless, health centers they're expected today to be in networks more and more. They will be expected to align themselves through joint ventures with inpatient facilities, with specialty practices, with hospital-based practices. And of course, health centers and health center networks are going to be gateways for piloting a lot of Medicare and Medicaid pilot reforms. We think that we will see a lot of collaboration between the Centers for Medicare and Medicaid Services and the Health Resources Services Administration, moving to get health centers heavily involved in accountable care organization formation, either among themselves or in partnership with far larger networks. And they are already, of course, moving rapidly into the world of medical homes, although they probably already are there. What do they need to meet these challenges? Congress has already recognized one of them, that is the major capital investment that the Affordable Care Act represents. They're going to need continued operating support for their uninsured patients. Even in the strongest of all worlds, their numbers are probably still going to be 1 in 5, 1 in 4 patients who are uninsured, and that number should stay. Somebody asked me once what I would consider to be the greatest success story of health centers in 2019, and my answer was that their uninsured are at 25%, because that means that they've been true to their mission. And we are so far from universal coverage that if health centers do not continue to show this high volume of uninsured patients, even in a reformed era, and have to think about practicing in that kind of climate, there will be something very wrong. They're going to play an integral role in identifying and helping to enroll and retain newly eligible individuals. They're going to have to be able to play incredibly strengthened role in managed care, qualified health plan certification, in the new order of things, with a tremendous emphasis above all on continuity of care. That is, they're going to have to be in networks, both in exchanges and in Medicaid, where we are projecting, based on some work we're doing now, separately, probably as much as a 50% movement between Medicaid and the exchanges among low-income subsidized individuals because of fluctuations in income at the lower end. So this role of health centers in both kinds of service networks is going to be critical. Otherwise, their patients will have no continuity of care. They're going to need a favorable legal environment, just like all providers will, for affiliation into clinically integrated models. They're going to need priority for inclusion in payment reform demonstrations. They're going to have to be a priority for National Health Service Corps placements. They're going to need a lot of changes in state scope of practice laws, because the need to grow capacity also means the need to be able to task shift as much as possible and to use practitioners within the scope of their training, not just within the scope of their licenses. And finally, they're going to have to make major alliances with health professions training programs, from community colleges to advanced placement programs of highly qualified health professions. So they have a lot of need if they are going to grow to meet this need. On the other hand, they've been given enormous tools to do so, most notably the capital infusion, a very strong operating structure, and I think most importantly, very strong accountability for the scope of their practice. Thank you very much.